Thank you everyone for coming along today. On behalf of the International Humans in Space Summit, I would like to welcome you to our very exciting panel on anesthesia and long duration spaceflight. And I would like to say a very special thank you to our American colleagues who are joining us today to present to us and join in discussion, and to our panel moderator, Anna Ruskin, who has also organised the panel for us. So we're very grateful to you, and all very much looking forward to hearing your talks and the discussion today. So without further ado, I will hand the floor to you. Thank you.
Well, thank you so much for inviting us and for giving us this opportunity. So our first speaker today is Dr. Keith Ruskin, who's going to be talking about an overview of anesthesia in deep space, as well as anesthesia equipment.
Okay, turn your thing off. Well, thank you very much. I'm going to share my screen. Hang on a second here. There we go. So can everybody see this? That's one of the artifacts of the Zoom age. Can everybody see this? So I'll be talking about equipment and supplies that you might need on during a long duration spaceflight. And I'll start with a little introduction about some of the problems and limitations of the environment. So I have no financial disclosures, no conflicts of interest. I am partially funded by a cooperative research agreement with the U.S. Federal Aviation Administration, and that's to look at alarms, alerts, and warnings in air traffic control. And I'd like to give a special shout out to Greene, one of the first space physicians. Greene was an anesthesiologist who got his MD degree in 1946. And he was in charge of a bomber wing. And then as he began to study the effects of physiology using his training as an anesthesiologist, he began to do the earliest space flights with monkeys and experimenting on monkeys to see how they tolerated space flight. So anesthesia has been involved with space flight since the very beginning. Some of the problems that you have if you do need to do surgery during space flight is you're isolated. You don't have other people that can come in and help you. The resources you have are whatever you brought with you. Microgravity is an issue because it's impossible to remove air bubbles. Both the patient and the proceduralist have to be restrained. All the equipment has to be restrained. If you're considering a general anesthetic, you've got to deal with airway management. And if you choose to do put somebody to sleep, volatile anesthetics don't work because there's no gas scavenging and you just can't release anesthetic gases into the environment. The equipment to do general anesthetics and to do surgery is big and heavy, meaning there's a very high cost to launch. Particularly, because it costs thousands of US dollars per kilogram to get something on orbit, and then from there to wherever you're going. And after the surgery, you've got to take care of the patient, both from a post as they recover from anesthesia, and then also as they recover from their surgery. We do have an analog for this. This is yet just one example. In 1961, a surgeon had to remove his own appendix during winter over in Antarctica. They just couldn't get medical people there, and the guy did it himself. There's another story about a woman who discovered a lump and did her own lumpectomy, also under local anesthesia. So these things have been done before. Which leads me to the first question, which is, if we know that a certain number of people have their appendix, their gallbladder go bad, why not just take them out before space flight? And the problem is that any surgery you have has complications, and in particular, increases the risk of small bowel obstruction. And this is a fascinating study where this group did a probabilistic risk assessment using a Monte Carlo simulation to look at whether or not taking out somebody's appendix or gallbladder during a hypothetical two and a half year Mars mission would make sense, if it would reduce the risk of injury. And what they found was exactly the opposite. If you had surgery, you're more likely to have a medical emergency. There was a slightly higher risk of loss of life from appendicitis or cholecystitis if you didn't have them taken out beforehand. But overall, your likelihood of having a medical emergency was a lot higher if you did. So their conclusion was, don't do it, just leave people go. Which means that people may very well need surgery during space flight. Airway management is an issue, and Dr. OConnor will talk about that. Fluids are an issue, and Dr. Clebone will talk about that. And so what you really need are specialized equipment for airway management, if you choose to do it, for IVs, for infusion pumps. Everything needs to be purpose designed. This is an example of how you manage making things that you don't have. This is part of the Made in Space program. And this is being done right now on the International Space Station. Ground control people will send up plans, and you have a 3D printer here that will make it. And the idea is that if you do need to make if you do need surgical instruments, you can make them on orbit or during en route to wherever you're going, and use those instruments. And in fact, this has been validated in at least one simulated austere environment. The Hawaii Space Exploration Analog and Simulation Experiment, the High Seas Experiment, is this long-running project where people are sent to the slopes of mountain in Hawaii, and they can't leave their environment except in a hazmat suit, and they're given missions. And one of their missions was that they were told to print plastic surgical instruments, including a sponge stick, a towel clamp, a scalpel handle, and tooth forceps. And then they were given simulated surgical tasks, dissecting something out, isolating a piece of tissue. And there were 5 crew members who did this with no surgical experience, but they were taught how to prep, drape, make incisions, and how to suture things over this asynchronous simulated radio propagation delay system that they have. And they were able to do all the tasks that they had to do. And in fact, they were then told, oh, by the way, if you look in this box, there are some actual surgical instruments, try those. And there was no difference in their ability to accomplish the tasks using the control instruments that they had access to, or the 3D printed surgical instruments. So the Made in Space technology actually works. Another problem, again, if you're going to do surgery, is in terms of what equipment do you bring an ultrasound machine, because ultrasound machines are useful for a lot of different applications. We'll talk about some of those in a minute. And there have been a couple of articles suggesting that on Earth we use interventional radiology using X-ray equipment. In space, you could use ultrasound equipment and guide percutaneously inserted catheter up to wherever the problem is and treat it that way. The advantages are minimal sedation because you're just going through a puncture in somebody's groin. Catheters are very lightweight, and you can accomplish at least some surgical procedures using 1/4 of a kilogram, as opposed to surgical instruments, which may weigh up to 100 kilograms. There may be a lower risk of complications, and further study is needed. And so what they suggested doing this either on a KC-135, which is a refueling airplane, microgravity flights, or remote bases like the High Seas mission. And in fact, this has been done. Here's a study looking at anesthetizing pigs on a Falcon 20 aircraft, flying multiple maneuvers, including microgravity maneuvers. And the team included anesthesiologists, a life support system, and various supplies. The conclusions, not surprisingly, is that this is a very physiologically and psychologically challenging environment. Motion sickness was the big problem. And speaking from personal experience, you do acclimate fairly quickly. But in this environment, they were looking back and forth between different monitors and trying to do different procedures. And if you did that during an abrupt turn or acceleration or deceleration, that seemed to cause the most problems. We mentioned regional anesthesia, and here's an example of 2 astronauts on orbit using an ultrasound machine, in this case, to visualize the neck vasculature. But there's less of a physiological impact than a general anesthetic. You can essentially use the same techniques. If you have your drugs drawn up and you have the catheters, you can apply the local anesthetic to a nerve and numb that part of the body. So less equipment. The procedures can be taught, and you can manage a wide range of injuries and surgical procedures. I'm just going to wrap up with an interesting study that was published last year in Surgical Innovations. This group deconstructed a laparoscopic appendectomy and created a hierarchical task analysis. And their goal was to give a list of steps that a non-surgeon could do to do an appendectomy. So the first thing they did, they got a surgeon, an assistant, and an anesthesiologist, and they talked through every single one of these steps. And they accounted for failure modes, which, theoretically the patient didn't respond well to some procedure. And they looked at what they would need to do and which actions and supplies would need further study. And there's an iterative process. They did it over and over again, and they did a scoping literature review. And that led to a spreadsheet with links to instructional videos and an expert review. They then compared their steps to a pre-recorded procedure and thought it was close enough. So they then did a simulation asking three non-surgeons to do a laparoscopic appendectomy on a fresh cadaver. And they were able to do it. And they were able to do it using fewer items than they actually needed during the initial hierarchical task analysis. And just 3 trocars, a couple of instrument changes, and these non-surgeons were able to follow the step-by-step procedure to do a laparoscopic appendectomy. So there have been experiments, again, in simulated gravity on the International Space Station about open surgery. The problems, to reiterate what I said at the beginning, you've got an autonomous crew, you've got instruments that are made on site, you've got a restrained patient, surgeon, and all the equipment, and you're worried that blood and fluids could contaminate the environment. So Panesar published a really good review article in the British Journal of Surgery hypothesizing some ways to manage this. And the idea would be to create an enclosure over the surgical site or an enclosure for the entire procedure, and they called it a trauma pod. And here's what the thing looks like. You have a special wing of the spacecraft with a restrained surgeon doing robotic surgery on a patient. So I'll leave you with that, and I will thank you very much for your kind attention.
Great, thank you so much, Dr. Ruskin. So our next speaker is going to be Robert Fong, who will be speaking about anesthesia drugs in deep space.
Okay, hello. So let me just share screen here. Okay, so, all right. So I'm going to be talking today about anesthetic pharmacology as it relates to the possibility of providing anesthesia for surgical procedures in deep space. And so some of you may remember this memorable scene from a movie Prometheus that came out in 2012, where one of the main characters has to get essentially a cesarean section to remove an alien baby that's incubating within her. And, in that scene, if you watch it closely, the anesthesia mounted only to the machine spraying that red local anesthetic on her skin before the robot arms then made incision and pulled out the alien baby. In real life, there are many issues with that scene, but spraying local anesthetic on the skin tends to not be enough and won't work to provide anesthesia for deep incisional surgeries like this. Not to mention the fact that we haven't yet gotten to the technology where an autonomous robot could perform a surgery like that. And so when we talk about anesthesia, what exactly do we mean? And so there's multiple aspects to the anesthetic state that you need in different quantities depending on what procedure you're having. Important to the patient primarily is often lack of awareness. They don't want to be aware and awake to see what's going on, to see somebody cutting into them. Analgesia, obviously surgery hurts. And so we need to block the sort of pain pathways that will make surgery hurt. Interestingly, even if you are unconscious, your body still responds to pain and is aware that you have a noxious stimulus. And so that needs to be blocked because that has untoward effects on your physiology. Amnesia, having a major surgery can be a traumatic event if you are aware and also remember it. And so it is helpful to provide amnesia in some cases. And then immobility, this is more for the proceduralist, right? There are certain procedures in which it's not that important to be completely immobile, but others where you're doing something very delicate, where obviously any movement could be catastrophic. Okay, and so on Earth we customize our anesthetics to provide those 4 aspects of the anesthetic state in different amounts. So rather than thinking of each of these elements as being binary, sort of imagine that you have a slider for each of these: how much awareness, how much analgesia, how much amnesia, how much immobility. And what we call a balanced anesthetic approach leverages multiple categories of pharmacological agents who are best at providing those elements. And so, for example, hypnotic agents are what we primarily use to provide lack of awareness. We've all heard of opioids because of the recent epidemic and their effects on analgesia. Benzodiazepines are very useful in ablating short-term memory formation, and neuromuscular blocking agents provide the paralysis that the proceduralist might need. Now, there is overlap in a lot of these drug categories and what they are able to do. And in fact, as we sort of come to the end of this, we'll see how we might leverage that so that a untrained or minimally trained provider does not have to use such an extensive cocktail of medications to perform an anesthetic. And so we can also think about the anesthetic state as a sort of a continuum that ranges from, being completely awake to basically being comatose. And along the way, depending on the dose of medications that you give, you can progress through minimal sedation, moderate sedation, deep sedation, and then finally general anesthesia. And as you look at this table, what you'll see is that as you become deeper in your anesthetic, you become less responsive to stimulus and more tolerant of painful stimulation, such that more dramatic, noxious surgical procedures would require you to be closer to the general anesthesia end, whereas small procedures will allow you to function on the more minimal sedation end. As you will note, as you get deeper under anesthesia, there's more stress to your cardiovascular system and more respiratory depression. And so that eventually, somewhere in between moderate and deep sedation, your probability of having to instrument the airway and provide mechanical ventilation becomes very high. All right, so what these quotes are meant to show is that, there isn't a lot actually known experimentally about providing anesthesia in a deep space environment. And that sentiment is pretty much unanimous in the literature. There haven't actually to date been any instances of an anesthetic needed to be provided on a human, on a space or a deep space mission. They have anesthetized monkeys, as Dr. Ruskin mentioned, back in the mid-90s or so. But as a result, a lot of the thoughts about what might be the optimum technique are derived sort of largely theoretically based upon, our experience with anesthesia on patients that are earthbound. And so, there are multiple anesthetic strategies, even for particular procedures. One can do what we call general anesthesia, which means rendering someone unconscious, right? Which most of the time requires, airway instrumentation and mechanical ventilation, right? But that will allow you to tolerate a procedure anywhere on the body. Local anesthetic techniques are when you have sort of superficial localized injuries. So if you get a cut and you have to go to the ED to get it sewn up, oftentimes they could just inject some local anesthetic in the area. And then you have regional techniques that will be the subject of a subsequent talk on this panel that include things like, epidurals or spinals, which we call neuraxial techniques, and then also regional nerve blocks, which often use the guidance of an ultrasound, as Dr. Ruskin referred to. And here's just an image of a provider performing an ultrasound guided nerve block, presumably to fix this guy's injured hand. And so, choosing the right anesthetic technique, as multiple may be possible for a particular procedure, involves trade-offs, right? And so as you think about a spectrum from regional anesthesia through conscious sedation to general anesthesia, in general, I think it's fair to say that there is more provider training that's probably necessary to perform a regional anesthetic, as it is a procedural technique, and less training required to provide a general anesthetic. However, physiologically, there tends to be greater risk of a general anesthetic and lower risk of a regional anesthetic technique. Now, regional anesthetic techniques are not without risk, some of which can be very serious, but those are often very rare. And so these are the trade-offs that one has to balance when deciding what is the best protocol for particular procedures in which multiple anesthetics are possible. And so this is extracted from a review. So this is what we call the list of space exploration medical conditions that tabulates the type of procedures that one is likely to encounter on a space mission. And this isn't the exhaustive list. This is just a list of those 17 or so conditions that are likely to require anesthesia to perform the procedure. Now, this comes from a review in which the authors advocate strongly for general anesthesia over regional anesthesia. But in fairness, I've kind of highlighted those procedures where regional anesthesia is a viable option, definitely in place of general anesthesia. And in yellow, depending upon the anatomical locations of those particular conditions, regional anesthesia might be a possibility. So what kind of drugs are we talking about if we were to provide sedation or general anesthesia? And so here are some common agents. They divide themselves into inhaled agents and intravenous agents. And these are their chemical structures and the dates in which they were introduced. Ether was the first one. Actually not a bad anesthetic, precluded in modern day use because it's actually flammable. So in the modern day of electrocautery, one doesn't want to explode their OR with a flammable gas. The ones that are in common use, isoflurane, desflurane, sevoflurane, are the ones that are listed here. We have established, though, that gas delivery is not really possible in the confined environment of a spacecraft or a space station. And so really we can cross that off the list as potential candidates for what we might use to anesthetize somebody. Aside from that, they have some cardiovascular depressant effects, which, given the physiological changes of microgravity, are not favorable. And there are some rare but very serious side effects or adverse effects that some people may get that can have a high mortality, if unrecognized and untreated. And so, a lot of the constraints on designing the perfect anesthetic and choosing the right drugs depend upon the physiology that is engendered by microgravity environment. And so many organ systems are affected, right? And so you have obviously a neuromuscular deconditioning because you don't have the effects of and the stresses of microgravity to deal with. But, many other systems are affected as well. Your neurovestibular system, right? You can often, have dizziness and nausea as a consequence of that. You have a fluid redistribution due to the effects of loss of gravity, right? That essentially causes fluid to pool in your upper half of your body rather than the lower half of your body due to the loss of gravity. And you have effects on your cardiovascular system. You have a decrease in your red blood cell mass. Because of that neuromuscular deconditioning, you also have bone turnover that causes disorders in your calcium metabolism. Such that actually, you have often high calcium levels that can lead to things like, kidney stones and things like that, theoretically. And then, once you're, if you go beyond the Van Allen belt, right, and now you have exposure to radiation and potential deleterious effects of that on your physiology. And so as general anesthesia engenders a lot of effects on the cardiopulmonary system in particular, from this review by Komorowski here, these are some of the specific changes to your cardiovascular system. And so in general, you see a decrease in blood pressure that comes from disorders in our mechanisms that regulate that, changes in our fluid volume, changes in cardiac output, dysfunctional reflexes that normally help us maintain blood pressure and so forth. And I mentioned before that you get this sort of chicken man phenotype, when you're in space because of the pooling of vascular fluid in the upper body rather than lower body, so that you get these thin chicken legs And then you have this vascular congestion in your head and upper thorax and so forth. And that can lead to a lot of symptoms, even if you don't need surgery, like nasal congestion, headaches, and it definitely has implications for airway management that will be discussed in a subsequent part of this panel. And so all that to say, and there's some other physiological changes that impact an anesthetic as well. You have decreases in GI motility, which mean that as things don't move as quickly through your GI tract, you now become an aspiration risk as you go under general anesthesia. There's endothelial dysfunction, which is thought to be the cause of your impaired responsiveness of your blood vessels. Decrease in immune function, which makes you a greater infectious risk. And then neuromuscular deconditioning, has consequences for example, what agents you might use to provide neuromuscular paralysis should you need it for the procedure. And so all of this to say that an optimum, anesthetic plan or protocol should prepare for the worst case scenario. And that scenario is one of a deconditioned, hypovolemic, anemic patient with cardiac and hemodynamic dysfunction who is an aspiration risk and difficult airway being cared for by a minimally trained provider. Okay, so that's your worst possible scenario. And so having ruled out the inhaled agents, right, intravenous anesthetics are the ones that you would be choosing from if you were to provide sedation or general anesthesia. And so in general, most of these agents, with the exception of ketamine, and that will be important in a couple minutes here, are thought to function significantly by agonizing these receptors that we have in our nervous system called Gaba receptors. And you can think of Gaba receptors as being off switches within the nervous system. When they are engaged and on, they create these currents, these hyperpolarizing currents that make your neurons less likely to fire. And so in general, you can say that engagement of these receptors and activation of these receptors tend to power down the nervous system, right? And thus provide your loss of consciousness and so forth. And so here are all of the agents that actually have binding sites on the GABA receptor. There's a whole active area of research into the full mechanism of these anesthetics, because it turns out that just invoking GABA is not a complete explanation, but that's sort of beyond the scope of this talk. So, as we look at this list, there are some that are less suitable than others. So, for example, barbiturates, of which thiopental is a primarily used example of that class, and propofol, which we use very commonly to induce anesthesia in earthbound patients. The problem with them is that they have cardiovascular and respiratory depressant effects. And that is a combination of them directly depressing the heart and its function, but also dilating blood vessels and exacerbating the vascular pooling and the drop in blood pressure that you already have. You might argue that, for a patient not needing a procedure, that all of those physiological changes aren't that deleterious because microgravity removes a lot of the stresses that create our normal physiology on Earth. The problem comes in when you then have to anesthetize somebody and you engender additional depression of the cardiorespiratory system, and that can lead you down a bad path. In fact, Halford once commented that barbiturates, for example, because of their hypotensive effect, are the ideal form of euthanasia in war surgery, suggesting that you probably should not use them in that context. Propofol is actually the most hypotensive of the IV agents. The other thing is that because it's not very soluble in water, it's suspended in a lipid emulsion. So it has a limited shelf life, when the bottle is closed, and it only lasts 48 hours once you open it before you worry about bacteria growing and being contaminated and so forth. Also, these agents are only available by IV administration, okay? And so then we move on to etomidate, which at first glance seems not like a bad option because it has less effects on your cardiovascular and respiratory system. And in fact, we often use it as an induction agent for trauma patients who are in shock and have lost a lot of blood and so forth. The downsides, though, is that it does engender significant nausea and vomiting. Inflammation of the vessel in which you give it is not uncommon. And then also it has this phenomenon of adrenal suppression, where it inhibits some of the enzymes on the pathway that you need to make cortisol, which is your stress hormone in your body, from cholesterol. And since surgery is a stress that your body is undergoing, that sort of neurohumoral response that's appropriate to that stress can be ablated and cause some problems down the line. So as a result of that, etomidate is probably a better option than the barbiturates and propofol, but is there something better? And that's where we come to ketamine, right? So ketamine is a little bit different than the other agents in the sense that its main mechanism of action is thought not to reside in its ability to antagonize GABA receptors, but instead binds to another kind of receptor in the nervous system called NMDA. As a consequence of that, not only is it hypnotic and amnestic, but it's also analgesic as well, right? And so this agent is commonly used in the treatment of chronic pain syndromes, and there have been reports of being able to perform surgeries with ketamine and not needing to use any opioids whatsoever, and thus avoiding all of the downstream side effects, untoward side effects of having to give opioids as well. Other advantages, instead of being cardiovascular depressant, ketamine actually releases endogenous catecholamines. Those are the signaling molecules that amp up your cardiovascular system. And so in general, it increases your heart rate and blood pressure, unless you have a situation where you're very, very sick and, very, very volume depleted and critically ill. In those contexts, ketamine may have the opposite effect because it does exhibit some direct myocardial suppression as well. It can cause some engender bronchodilation, which is helpful in terms of getting air in and out of your respiratory tract. Causes minimal respiratory depression. It's available in powdered form, so it actually has a 20-year shelf life. And so that makes it, for long missions and so forth, that may be a more viable option to be able to store. It can be given IV or intramuscular, so even if you don't have intravenous access, you can still administer it. Has a rapid onset. It has a high therapeutic index. In other words, the ratio of how much you give before it's toxic to the ratio of how much you need to give to be effective is much higher for ketamine than it is for some of the other agents. So in general, it's about twice as safe as thiopental, 3 times as safe as propofol. And this is important if there are less experienced providers who are administering these agents, makes it less likely to overdose and create adverse consequences as a result. As a result of all these advantages, ketamine actually is on the World Health Organization list of essential medications. Now, ketamine is not without its side effects, as any agent is. For example, one of the well-documented ones is the sort of dissociative effect, this feeling that you're disconnected from your body, which can be very unnerving for folks. And also these vivid nightmares, which in particular happen with a higher frequency in children. But it turns out that these effects can be mitigated by midazolam, which is a benzodiazepine, right, in the same pharmacological category as Valium, right, which we think of as an anxiolytic. You can increase your intracranial pressure, which for a normal patient that doesn't have a head injury and doesn't have high intracranial pressure is not a big deal. But even in the context of elevated ICP, for example, in traumatic brain injuries and things like that, it turns out that in a previously sedated patient, the effect of ketamine on ICP is minimum, in fact, may actually be in the opposite direction as well. And ketamine can increase salivary and tracheal bronchial secretions, which has consequences for airway and aspiration, but you can mitigate that by administering an antisalagogue, in other words, an agent that will dry up your saliva. Glycopyrrolate is one example of such an agent that you might give to mitigate that side effect. Okay. And so finally, I want to close with just a quick mention of neuromuscular blockade, which was alluded to before. The neuromuscular junction involves an acetylcholine receptor, which allows your neuron to trigger your muscle to contract. There are 2 classes of these neuromuscular blocking agents. One which is called depolarizing, which basically activates the receptor and allows ions to flow in and out before then causing a paralysis in your muscles. And then the non-depolarizing class, of which those are some examples, simply block the receptor competitively. The problem with succinylcholine is that in cases where patients have neurological or neuromuscular injuries, the muscles seem to compensate by proliferating these acetylcholine receptors. And one of the things that happens when these receptors are activated is that potassium, which we primarily store in the cells in our body, is poured out into the plasma. right, into the bloodstream, and high levels of potassium can be lethal. In fact, that's how we stop the heart in cases of, cardiopulmonary bypass when we do cardiac surgeries, to give a high potassium solution. And so stopping the heart when you don't want to is in general not a good thing. So if you need neuromuscular blockade, then we should probably avoid succinylcholine. So putting this all together, just to summarize, there's not a whole lot of data on humans receiving anesthesia in space, but the optimum anesthetic technique should consider the constraints of resources that are available, the environment, and then importantly, the physiological changes engendered by that environment. Regional versus general anesthetic involves some nuanced trade-offs. Intravenous anesthetic techniques are required if you want to do general anesthesia. Ketamine in combination with midazolam is endorsed by experts who've thought about and talked about this in the literature. You want to avoid succinylcholine when neuromuscular paralysis is needed. And, we need to do further research to sort of refine these optimum protocols, as Dr. Ruskin talked about, in remote or austere environments. Trauma patients, it turns out, can be a good model for hypovolemic patients and so forth. So with that, I will conclude my part and return it to the moderator.
Thank you so much for that outstanding talk, Dr. Fong. Next up, we have Dr. Michael O'Connor talking about the airway and anesthesia in deep space.
Excellent. Well, thank you very much. Rob, if you can stop sharing, I will start.
Yep, I will do that presently. So I should be starting.
All right, I see. Perfect. So thank you, everybody. I'm Michael O'Connor. I'm an anesthesiologist and intensivist at the University of Chicago, and I've been asked to talk about airway management in deep space. I have no conflicts of interest related to this talk. There's actually a substantial literature about healthcare in space, as my colleagues have already kind of made apparent to you. Much of it's what I call a very thoughtful analysis, and honestly, there's a lot of good information there. There are some very nice and substantial reviews of healthcare events in spaceflight thus far. We'll talk a little bit about those. There have been studies using simulation in microgravity environments, and people have actually even begun to offer and author guidelines about how to do this, that, or the other thing in space, some of which I find very problematic. As my co-panelists have already pointed out, there's zero gravity or microgravity. Newton's laws still apply, and cohesion and other phenomena of physics actually become dominant in spaceflight. Another one that we'll be talking about perhaps at the end is our friend Bernoulli comes to haunt us. NASA regards these things as pretty substantial. So they say a Mars flight is going to have a 6-person crew conducting a 900-day mission. Alternatively, there will be a 4-person crew for up to 1,100 days. And so I think 6 people in 1,100 days is probably a pretty reasonable view of in fact, what we're going to be seeing here. And finally, if you think about really deep space, you realize that there's a time lag that's pretty substantial. And so radio communications are going to take between 4 and 20 minutes to reach from somewhere around Earth to Mars, depending on the relationship between the two. So nobody's going to be talking to anybody through any kind of a procedure in a flight to Mars. Basically, if you don't have it with you, if it's not on a video or somehow in a repository on your spacecraft, it's not available to you. In terms of the epidemiology here, experts have estimated that basically there's going to be a 1 event every 2.8 years for a crew of 6. That is to say, you're going to have an emergency on the way to Mars and back. The 95% confidence interval around that is such that you could have 0 events or you could have 3 events. But you should count on having at least 1. And we'll talk about that list in just a minute, right? Interestingly, NASA's threshold for acceptable fatalities is actually higher than what people project as the risk of death. You see here that the kind of probabilistic risk assessment says that there's going to be about a 0.25% risk of mortality per year on a trip to Mars, On Earth, on the surface Earth, the risk is actually a little bit higher at 0.39%. Like I said, NASA has considered 3% to be acceptable. Other people have already kind of talked a little bit about that. There's cardiovascular deconditioning. On a transit to Mars, there's a risk of lethal radiation exposure. There's vision impairment. Some people have intracranial pressure elevations. There can, of course, be toxic leaks into the environment. If you have problems with craft temperature regulation, you get hypothermia or hyperthermia pretty quickly. And of course, there are all sorts of things that plague us on Earth that can also happen in transit. One of my co-panelists has already kind of gone over all this. I just want to point out that after a month and a half, you're adapted. In terms of the cardiovascular physiology, your heart rate ends up being about normal. Your blood pressure is about normal, but it's a little bit deceptive, and we're going to talk about that. Your central venous pressure actually typically goes down, and it goes down because your blood volume contracts. So there's basically less gas filling that tank. Interestingly, the absence of gravity makes a situation where you actually have an increase in intracellular and interstitial fluid, and so you actually get puffy in ways that are problematic. Globally, your cardiac systolic function is about the same. There's actually some diastolic dysfunction. Your systemic vascular resistance goes down because a lot of the squeeze that happens in your arterial circuit is to, in fact, distribute the blood flow pretty much in compensation for the forces of gravity as they apply across your body at that particular moment. As a consequence, the baroreceptor reflex also goes down because the baroreceptor reflex is actually what drives those changes in systemic vascular resistance. Now, as importantly, we know almost nothing about changes of respiratory physiology in deep space flight. And the reason is because it's much more difficult to study than it is to study cardiovascular physiology. So if you look at this very nice table, it says rapid shallow breathing, decreased total lung capacity, decreased tidal vital capacity, decreased forced vital capacity, decreased peak flow rate, decreased FRC. But all of these things are based on a small number of study subjects. They could be completely wrong. All right, they could be completely wrong. This is a really important figure to help you figure out what's going on. In planet Earth, down here on the ground, right, your baroreceptor reflex and your sympathetic nervous system kind of change the tone of your arterial circuit to provide blood flow to the brain. And in spite of the best efforts of your heart and your arterial circuit, the pressure head at the brain is not quite as high as it is at the level of the heart. And of course, the pressure down at the foot is actually pretty substantial. When you go to microgravity and the baroreceptor basically shuts off, what happens is there's less squeeze everywhere in your body. The effect is that the blood pressure is about the same everywhere, and the flow gets redistributed really to the head and upper torso, which is what produces that swelling and that beautiful figure that Dr. Fong showed. And that has the effect of making it so that all of this tissue is quite friable. All of this tissue is quite friable. And why is that important? That's important because when it's swollen and friable, that means it can bleed. And so somebody who's got a congested nose is somebody who's going to get a bloody nose if you try to stick something through it. In terms of the physics, we rely upon gravity to keep the patient and their head on the table when we go to manage the airway in somebody. And frankly, we rely on gravity to keep us in place as we leverage on a patient. And the other thing that we rely upon gravity to do is to keep their secretions pooled in whatever portion of their head or oropharynx we think of as a dependent. And this last one's really important because anything that's coming out of a patient may well just go into the air as opposed to follow the track of gravity. And this is something that we don't have a lot of experience with. This slide is a photo of an IV bag, and you can see that there are bubbles all throughout it. We would have to find some way to get those bubbles out of it before we administer it to a patient in space. And it's just an example of how problematic and frankly inexperienced we are in a zero gravity environment. Here are some very nice photographs from people simulating managing the airway in a microgravity environment. On the left here, we have, if I can get my pointer to work here. On the left here, we have a mannequin that's been strapped down, and here we have an operator that feels like he's adequately secured himself and he's about to do direct laryngoscopy, and here's his able assistant. Here we have another scenario where our same able assistant and our operator have switched places. I'm just going to point out to you that this particular operator, in the process of having done laryngoscopy, instead of levering the patient, he's levered himself into a position where he actually can't perform the procedure that he's attempting to. And so I've kind of annotated the slide. You can see that if you were to look here, he can't actually see that he's putting the breathing tube where he wants it to go. This phenomena is going to be extraordinarily difficult to overcome for a variety of reasons, one of which is if somebody needs to have their airway managed, the last thing you want to do is strap them so tightly to some surface in your vessel that it restricts their breathing. They'll be short of breath already, it'll make it worse. Additionally, if you have to mask ventilate them, that will make it even more difficult to take care of them. This is a very nice figure. Astronaut Scott Kelly establishing an airway with a mannequin using an intubating LMA, okay? And here's astronaut Kelly. I'm just going to point out to you that this particular patient, if you look at the fact that the head is rotated 90 degrees on the torso, he's actually performed a neck breaker simultaneously with inserting an airway here. This would be a really, really bad outcome. The procedure was successful, the patient's quadriplegic. And so all of this is much more difficult than we think it is, or we can imagine it might be. And what we've rated as success in some of the experiments that have been done may not have been. Many people are tempted to use videolaryngoscopy. This is an example of a videolaryngoscope right here. This operator has a videolaryngoscope, and so there's a camera mounted on the tip of the thing, and there's a little screen here, and they're using that to help them manage the airway. And the reason that that's so attractive is because amateurs, people who aren't experienced, novices, are very confident that they'll be able to get the airway in. I'm just going to point over here on this slide. Here are the expert operators that they sent up into microgravity, and here are the novices. You notice that the experts weren't confident that they could do direct laryngoscopy, and they were pretty confident that they could do videolaryngoscopy. The novices were pretty well calibrated about direct, and perhaps a little bit optimistic about videolaryngoscopy. And so we'll see how it goes, but the answer is it's likely to be more difficult than anybody thinks. Dr. Fong mentioned GI issues. There is, in fact, a decline in GI motility. If you've ever talked to anybody who's been out in space, at the space shuttle, or in the International Space Station, they will tell you that everybody is embarrassed by their bodily functions. In fact, they're embarrassed by their bodily functions to the point where many astronauts very deliberately spend most of their time in space dehydrated, so they don't have to manage their bodily functions in the embarrassing and degrading way that we require astronauts to. Because when things are expelled from your body under force, you can't control where they go. You can imagine the messes that you can make as a consequence of that. As a consequence, many of these people are completely stopped up, and their stomachs might be very full when the time comes to manage their airway. There are no secretions in any of these simulators, right? These are all basically mannequins, right? And in humans, you have clouds of saliva and clouds of coughed up secretions. And the difference is that they just don't fall dependently down to some surface on the patient's cheeks or mouth. They're actually going to be an aerosol. So every time you squeeze the bag, you're going to be pumping whatever is in their oropharynx into their lungs. You're going to have airway edema. It's likely that their airways are going to be more difficult than a normal person's. And the tissues are going to be very friable. That is to say, they're going to be very unforgiving of even minimal trauma. And once again, this is an instance where instead of kind of just trickling down by gravity to wherever it would go in the ground, the blood is going to basically float into the airway and obscure your view. Why is that important? It's important because a videolaryngoscope has a tiny little camera, at the end of a tiny little blade. And if there's a drop of blood on that camera, it's game over for that approach to managing the airway. So any secretions, any blood, all that's going to make it extraordinarily difficult. And of course, if your subject happens to have the misfortune of throwing up during all of this, that's going to be a spectacular problem. And once again, our suction devices that are designed and routinely used to manage secretions in an environment like that, they've not been validated in space. I can tell you right now, they're not designed to succeed in space. Finally, anybody who needs their airway managed is likely to require mechanical ventilation for at least a period of time, perhaps for days, perhaps for weeks. And it's unlikely that we'd be willing to lift that amount of equipment into any kind of craft that's going to be in a deep space mission. To close out, I've just got on the left here an example of what emesis looks like in a zero gravity environment. You can see that it's not pretty, and that's the view you'd have with your videolaryngoscope if you got a little bit on your videolaryngoscope. This other image here, this is actually from an extravehicular activity on 16th of July of 2013, and this is when an astronaut nearly drowned in their spacesuit. And what happened was there was a failure of their environmental maintenance unit, and it was leaking water into their spacesuit, and so their helmet was filling up with water. Interestingly, every time they breathed in, they sucked water in or towards their face, and every time they exhaled, our friend Bernoulli made it so that the water came even closer. So by the end of the mission, they were actually out of communication because they were literally, their nose and mouth were covered with water. And with that, I will stop sharing and hand the session back over to Anna. Thank you very much.
Thank you so much for that really outstanding talk, Dr. O'Connor. Really appreciate it. So just to close up, I have a talk about intravenous lines and a little bit about regional anesthesia in deep space as well. Some of this has already been covered, and I want to leave a little bit of time for questions. No disclosures, but we'll talk about why would you want an intravenous line and what is it, and a little bit about regional anesthetics as well. So as you probably know, an intravenous line is where they poke you before surgery, but what it really is getting that tiny catheter into the vein. Can be done under ultrasound, can be done without an ultrasound. Sometimes we even do them when we can't see a visible vein, known as a blind technique. It's not completely without risk. You're breaking the skin. There's a risk of infection. There's a risk of poor wound healing, especially with the in space, especially with the edema that you have due to the microgravity changes on the body. So it can cause problems by itself. Why would you not give an oral medication or an intramuscular medication? Well, the intravenous route is going to be faster, oftentimes more reliable. And if you need an emergency medicine given, if you do get that cardiovascular collapse or cardiovascular changes that my colleagues talked about, it will be the fastest way of administering life-saving drugs to then raise the blood pressure and raise the heart rate. So the first intravenous line in space was not until 1993 on the Columbia mission. As my colleagues mentioned, with the fluid shifts that you have in space, the decreased intravascular volume, they did this particular experiment to try to increase that intravascular volume again. So IVs, as I said, not without risk. You can, if the IV is no longer in the intravascular space, so the fluid or drugs that you're giving in the IV go somewhere else, it's something called infiltration, which is sometimes easy to detect, but sometimes not easy to detect. And that fluid and those drugs, which can be caustic outside the vein, can cause edema, leading to a wound that will need to be healed in a difficult environment. Probably the biggest problem with intravenous lines is that usually it's dependent on gravity. This is an intravenous bag and then a drip chamber below. And every day in the operating rooms, we depend on gravity for flow. So in the microgravity environment, they're going to have to be on a pump, which increases the difficulty, increases the equipment that you need. So it will have to be actively pumped in and could possibly also increase the risk for the IV infiltrating because you're forcing the fluid in with this pump device. Obtaining sterile IV fluids in space is also a huge problem. They have a limited shelf life, there's contamination issues, very heavy, you can only carry a certain quantity. Another issue is the possibility of an air embolus. Dr. O'Connor showed an outstanding picture about how in microgravity, the air no longer goes to the top of the intravenous bag as it does in this picture. Instead, it's spread throughout the bag. And an air embolus, in many cases, can be similar to any other type of blood clot in that it actually stops the flow of blood. So a large enough air embolus, the size of a soda can, which really isn't that big, in the heart will actually stop the heart because it will stop the flow through the chambers and it'll be filled with air instead of blood. Here's another picture of that IV bag that Dr. O'Connor showed with the air distributed throughout the bag. So how do you solve this problem? Bags of IV fluids are not really going to be practical for a multi-year deep space mission. So they have the IV-Gen experiment, intravenous fluid generation for exploration missions. And this device is designed to remove air, bacteria, sterilize the IV fluid itself just from the drinking water. And finally, I'd like to talk about regional anesthesia. My colleagues talked about that a little bit. They do require a high level of skill to do peripheral blocks. They're in young people with a reasonable level of fitness. They are somewhat easier, although with the patients being a bit puffy and edematous, they may be a little bit tougher. So peripheral blocks for surgeries where they work or procedures where they're a reasonable option may be a good option. Unfortunately, those spinals and epidurals are pretty doubtful because they actually depend on gravity. So looking here, here's a picture of the spinal cord and the cerebrospinal fluid. So most people are probably familiar with the concept of a labor epidural that's given to people giving birth. Similar concept goes in a slightly different space for a spinal anesthetic, but it's really anesthetizing the spinal cord, and an amazing procedure because you're completely numb below the level where it's done. The problem is these depend on gravity so that they sink down. If you're sitting up, depending on the procedure you want to do, you might sit the patient up and then the local anesthetic sinks down. You might lie them down a little faster, but it's still dependent on the local anesthetic staying somewhat in place where you put it. If the local anesthetic rises too high, it's something called a high spinal. And you can imagine as you get higher and higher, you're anesthetizing really essential functions such as breathing, if you anesthetize the diaphragm and higher. And that can be a very dangerous situation where you then do need to emergently and quickly manage the airway. So it's unlikely that a spinal or an epidural, even though seemingly it would be a great option because you can just anesthetize the person below the level where you put it, it's pretty unlikely that that's going to be practical, at least with current technology and agents. Great, and I want to leave 3 minutes for questions, so we probably have time for one question from the audience. If people want to raise their hands. Chat that's been pretty active if you wanted to check that out. Many people have asked great questions on the chat during the presentation. Well, if we don't have questions, really appreciate Rowena inviting us and asking us to give this panel. And thank you so much for our outstanding speakers, Dr. O'Connor, Dr. Fong, and Dr. Ruskin. I learned a lot from listening to your talk.
Yeah, thank you so much. Thank you so much for coming, everyone.
Thanks for having me.
Well,
Thanks very much to all our panel members. That was absolutely fantastic. I really enjoyed it. I learned some new things too, and really fabulous presentations, really informative and insightful. And it's been wonderful of you to share your time with us today, and to all the effort that you put into preparing your presentations really came through. And I think we're very fortunate to have had the opportunity to hear from you. So if we could all please give a nice warm thank you to our panel members, virtually or otherwise. And once again, thank you also to everyone for coming along today, and we will be sharing the recording later on for anyone who couldn't make it. So if you have friends who might be interested, the recording will certainly be available later. So thank you all once again. We very much appreciate it.
Thanks. Have a good day.